Jim Harrop is up next, and I gave Jim kind of a tough topic of trying to kind of talk a little bit about, how do we kind of train the next generation of spine surgeons? Should we consider doing kind of a spine track and that sort of thing? So I'm sure, as always, Jim's going to be somewhat entertaining. So.
So I go to my residence, and I'm like, okay, residents, and before I get there, I want to say, the residents and the med students, I got to give you a lot of credit. Your talks have been fantastic, and the bar is so much better than when I was a resident with my slide carousel thing that you guys don't know what it is. But, dropping that was always horrible. So with that said I went to my residence, and I'm like, all right, let's talk about residency. What do you guys need? What do you think? And they're like, it's too long, and you don't pay us enough. So I said, okay, that talk's not going very well. So I said, let's go back, and this talk is, I want you to think about your patients, and that's the goal to think about. Number two is, I'm just gonna take a quick little poll. My one disclosure is I'm actually a neurosurgeon, so any of my vascular neurosurgery colleagues in this academic spine room? No. Brain tumor guys? No. Neuromodulation? Okay. How about any hip surgeons? No. I think I kind of made the point for the rest of this talk. We're at an academic meeting, but before I go there, can you guys hit the talk? I just want to give a little overview of my thoughts of my orthopedic versus neurosurgery colleagues. I don't know how many hours this takes you guys to learn. Yeah. Oh, the neurosurgeon. It's like ballet. So this is what we're up against as spine surgeons. So to go through this, are we competitors? And I think that's the first thing we got to get off. We got to stop thinking about and stop competing amongst ourselves. We are the same in a lot of ways, and we've learned for each other. I lived through the period where neurosurgeon and orthopedic guys couldn't be in the same room, and we've come a long way. And if you go through here, I usually listen to someone talk, and I try to figure out if they're an orthopedic surgeon or a neurosurgeon. And besides some of my orthopedic friends that, can't use something longer than 2 syllables, it's hard to do based on the slides. But the important point is this. John Ratliff was one of my partners. If you take a spine surgeon 5 years out of their practice, and my patients often ask me about this, I think we're very similar. We find our niche, we understand things, we constantly learn. And so the take-home message is, how do we get to that point faster? And to do that, I think you got to step back and look at the education pathway. So I'm going to go through the education pathway. I hope I don't have 2.3 minutes.
No, that's wrong.
Yeah. All right. So everyone knows the ACGME. You probably don't know this, but they have guidelines of what you do. 70 pages roughly of comprehensive knowledge and things to teach you how to teach a resident. So I'm going to trash the orthopedic guys first, and I'm going to trash the neurosurgery guys second. How many times do you think spine comes up in that 68-page document in orthopedics? Now, you could have spelled it wrong, but once. So that's depressing. That's our active training program for spine surgeons today. Very depressing. Neurosurgeons, a little bit better. The vascular surgeon who wrote this actually did put it in the introduction, but it's not very much. If you look at the whole thing, not very important as we look at education. So how about Residency Review Committee? Another different group of vascular surgeons in neurosurgery. And let's see what they wrote. So in orthopedics, again, you guys have, 5, 6 procedures that you need to do? That's pretty depressing. Neurosurgeons, we have a little bit more. But here's really interesting. Nothing's really changed. And I'm going to go back, and for the neurosurgeons, there's a book called Campbell's Orthopedic, and that's sort of their Bible. And if you go back from the start of residency, we have gotten a couple more operations out there, almost 3 times more surgeries. However, our time and our dedication hasn't changed in terms of residency and training. This is the most depressing thing of the day. You can be an orthopedic surgeon, or you can go through an orthopedic residency and only do 15 spine cases. That's the group that we're trying to say, is that adequate? I hope the hell my parents aren't having that person operate on them. And be totally true, the neurosurgeons aren't totally that much different. It's about 300 cases. Again, not something not something we aim for. So what I'm really getting at here is, why are we breaking up our specialties so small? I did 50 aneurysm clipped when I was a resident. 50. I'm like, useless me today. I did angiograms. I can put an A-line in better than most of the anesthesiologists in my hospital, but it's done nothing for me. It frees up my ACDF cases, but really. So how do you get graded? When you go to your residency and they grade you and say, are you being a good orthopedic surgeon? These are the milestones. How many times in orthopedics do you guys think on your milestones there's anything about spine? Crickets? That's about right. 0. There's nothing. And even if you go through the whole AMC milestones and try to find something, guess what? You only find it when you look in the pediatric section. And so it's kind of depressing that our societies, neurosurgery and orthopedics, put such a low priority on spine. And it kind of makes sense because they're not spine surgeons. So we need to take control of it if we want to do the best for our patients. And again, I trashed you guys, so here's the neurosurgery thing, exactly the same. They have one area where we call one section for spine. I'm going to go through this really quick. It doesn't really matter. Neurosurgeons tend to have longer time, but why, if we're turning out the same product, if you look into 5 years after practice, as I said, the orthopedic guys do it a lot more efficiently than the neurosurgeons. If I was the federal government, and I'm talking about $80,000 a year, I don't know how much you guys get paid a year, but $80,000 with health benefits, you're paying an extra $160,000 per person you educate. My idea is we should make it a smaller track, higher concentrated, and more goal-oriented. And really quickly, I'm just going to go through the data because you're already seeing yawns out there. This goes through and says, okay, the neurosurgeons do 6 times more than orthopedic times in spine cases during the residency, but still, the bar is really low. The funny thing is we are making traction and we are showing increases in our cases that are being done over the years. The problem is this is a really good study by the Canadians where they looked at it and they said, well, what is your confidence in doing this? The neurosurgeons were better than the orthopedic people, but guess what? Out of a scale of 4 being I felt confidence, most of them were low. Only 78% of the neurosurgeons said that they were confident in doing, all right, you can have my slides afterwards. You can do only 78% of the neurosurgeons said they were confident in being a spine surgeon or doing spine procedures, and only 50% of orthopedic surgeons said they were confident. So we're not doing a great job in our training. And you look at this, only 37 versus 16% of their time they're doing neurosurgery or spine. I'm sorry, I keep on falling into my world. All right, real quickly, what did we do? Residency was called a residency. Why? Because you resided in the hospital and you worked there and you were a mentor and that's what you did. The problem is we're sort of losing our focus here. In order to do something, technically, you need to do it over and over again. This is a program in autonomy showing that even the VA, where I don't know if you guys ever worked at the VA, the vets would let you do anything. And so over time, less and less autonomy of the residents in the VA. Residents' performance, this is a study from I think a guy from University of Maryland, orthopedic guy. He showed that with the work hour restrictions, residents are now losing almost 2 years of training in terms of the number of cases they did. And what is that? They looked at the skill set and said, oh, great, you're great on paper. You get the exact same scores pre and post 40 hours, but guess what you lost? You lost your technical skills. And this is over and over again if we look at the autonomy. In another study, they looked at every surgical specialty except for the important neurosurgeons, and what they show? Orthopedics had a 75% decline in the number of cases by autonomy over these years. Same thing. Here's the funny thing. Anyone know what the next round is? Orthopedics just did this, and they just did a pilot program in it. You're now going to be graded as you come out of your residency in competency. And the Canadians have been doing this, and the U.S. ACME is now changing their model towards this. So the question is with lack of training, lack of organization, and lack of focus, are we going to be able to train our residents to be competent? Not pass your written board, not pass your oral board, but potentially be technically competent. And the answer is there's a lot of things we need to do in in spine surgery that we don't cover. So, in summary, do we need a spine track? The question is, for the patient to get value in the spine track, you need to have better quality, which means you need to have more time in spine surgery, which is not being met right now. You need to improve education and make it focused about spine, which is not being met now. And you need to focus this education. And the second way you need to do it, you can either pay them less, which the residents would kill us, or we have to shorten the time to improve the overall value for our patients. Thank you.